Okay, so let's jump in. We're starting today's deep dive by looking at two tools that feel like they're worlds apart.
They really do on the surface.
Yeah, on one hand, you've got this simple brainstorming framework, the one that looks kind of like a fish skeleton, the thing you might doodle on a whiteboard in a meeting.
Hmm.
And on the other hand, we're going to use that same kind of structured thinking to evaluate, well, what Peter Drucker called altogether the most complex human organization ever devised.
The modern hospital.
Exactly.
And the connection, really, between those two things is systematic evaluation. Whether you're talking about that Fishbone diagram or the Ishikawa diagram, as it's
Yes.
also known, or this huge, complex Donabedian framework for assessing an organization.
Right.
Both of them are structured models. They're designed to stop us from getting overwhelmed by all that complexity.
That's the mission today. We're really focusing on these systematic frameworks. We're looking at tools that take these massive, sprawling problems and organizations and break them down.
Into pieces you can actually manage. Digestible, measurable, and hopefully fixable parts.
Yeah, and for this, we're pulling from two pretty different but related source stacks. One is all about root cause analysis using that fishbone diagram. And the other gives us this huge macro view on how you'd even begin to evaluate an entire healthcare organization.
And this should matter to you, the listener. I mean, no matter what field you're in.
Totally.
These are not some niche quality management documents. They're mental frameworks. By the end of this deep dive, you're going to have a kind of shortcut.
A shortcut how?
You'll be able to instantly categorize where a problem really is. Is it a failure of the structure? Is it a breakdown of the process? Or is there, an evidence gap? And that lets you stop just putting Band-Aids on symptom.
And start digging into the real foundational causes, the systemic flaws that are always hiding just under the surface.
Exactly.
So let's get into it. Let's start small with that micro-level problem analysis, the backbone of problem solving, the cause and effect diagram.
Let's do it.
So if you've ever been in a meeting trying to figure out why, say, a defect keeps popping up in a product or why your team keeps missing deadlines, you've probably seen one of these.
It was invented, or at least popularized, by Mr. Koru Ishikawa way back in 1968. And it just became fundamental to quality control. People like Dr. W. Edwards Deming adopted it almost immediately.
It's such a powerful way to visualize things because it really forces you to shift your mindset, doesn't it?
It really does. Instead of just jumping to what seems like the most obvious answer, it makes you categorize all the potential causes.
Yeah.
Systematically.
Okay, so how does it work? You start with the problem itself.
Right. You start with the effect. That's the specific, tangible problem you're trying to analyze. And you write that on the right side of your paper.
That's the head of the fish.
Exactly, the head of the fish. Then you draw a long horizontal line out from it. That's the backbone.
And then coming off of that backbone, you draw the spines. And this seems to be the critical part. These spines represent the major categories of all the potential underlying factors, the causes.
Yes. And the whole purpose of these categories is just organization. They're like filing cabinets for your brainstorm. They force you and your team to look beyond your immediate focus.
And the categories you pick, they depend on the problem you're trying to solve.
Completely. Depends on the context.
So let's start with the classic ones for manufacturing, right? The 6 M's. I feel like this is foundational for analyzing anything happening on a factory floor.
Oh, absolutely. The 6 M's are a great starting point for any kind of physical production. First, you have materials.
The quality, the specs, just the stuff you're using.
Yep. Then you have methods. So the standard operating procedures, the sequence of steps, the recipe you're supposed to be following.
Okay.
Third is machines. That's pretty straightforward. All your tools, your tech, the equipment involved.
Got it.
Then measurements. This one's important. It makes you think about problems with, say, calibration or data accuracy, or maybe you just have a poor monitoring system.
Right. And Mother Nature.
Or environment, as it's often called now. That covers things like temperature, humidity, lighting, or even the regulatory climate you're operating in.
And the last M is manpower, though, it's often updated to something more neutral, like people or personnel.
Exactly. And that one covers the human element, competence, training, attention levels, all of that. Now, if you shift over to a service industry, like healthcare or finance,
You use the 6 Ps.
you usually switch to the 6 Ps, yeah. Because the inputs and the infrastructure are just different.
Okay, so our source material lays these out as people, which is like manpower.
Yep.
Then process, which is basically methods. Policy, so the rules governing what you do. Plant, the physical building or facility. Program, the specific service you're offering. And then product, which is the resulting service or information.
But the key takeaway here is that the organization is fluid.
You're not locked into these categories.
Not at all. If you were troubleshooting, say, a specific IT network problem, machines might become hardware, and methods becomes procedures. You might even add a category for software. The point is, just to make sure your structure is comprehensive for your problem.
Okay, so you've got your backbone, you've got your category set up, now you start filling out the bones. And this usually happens through brainstorming or what our source calls a waste walk.
Yeah, a waste walk is where you physically trace the process from start to finish, looking for inefficiencies. But this next step is where the real value comes in. You have to drill down to the root cause.
Using the why technique.
The why technique. This is what separates the fishbone from just being a glorified to-do list.
Yeah.
You ask why over and over again. 5 times is sort of the classic recommendation.
Can you give us an example?
Sure. Let's say the effect is the machine stopped. Why? Because the fuse blew. Okay, that's cause 1. But you don't stop. Why did the fuse blow?
Because the motor overheated.
Right. Cause 2. Why did the motor overheat? Because the cooling fan failed. Cause 3. Why did the fan fail? Because the scheduled maintenance was skipped.
Ah, okay. So that's cause 4, and that falls under methods or maybe policy.
Precisely. And you keep digging until you hit a fundamental failure point that if you fix it, it solves the entire chain reaction.
Okay, but when you're in that brainstorming session, I can imagine these diagrams getting really messy, really fast. What if one category has 2 causes and another one has, like, 30? How do you keep the team from getting overwhelmed?
That's a great practical question. And it gets to the real-world challenge of using this. First, the sources advise, don't get hung up on perfect placement at the start.
Just get the idea down.
Just get the idea down. If it kind of feels like it fits under material, put it there. You can always move it later. Second, you have to embrace the imbalance. The diagram is actually meant to show you where the problem is concentrated.
So the messiness is the message.
The messiness is the message. If 80% of your causes are falling under methods or process, then the team has immediately identified its #1 target for improvement.
And that focus is what you take into the next step, which is validating these potential causes. But before we get there, we have to talk about this really critical warning in the sources, the manpower people trap.
This is, I think, the most vital concept to take away from this whole exercise. In any failure analysis, especially in service industries, the easiest and fastest conclusion is always human error.
Right. Someone made a mistake. They didn't follow the procedure. They were careless.
But our sources really caution that blaming the individual is, more often than not, a massive oversight. Because human error almost always masks a fundamentally bad process or a flawed piece of equipment or some kind of systemic failure in how the organization is set up.
So let's use a healthcare example, since that's where we're headed. Let's say the problem, the effect, is a nurse administering the wrong medication dose.
Okay, the easy, lazy answer is manpower. The nurse misread the order.
And a manpower-focused analysis would just stop right there.
It would stop there. But a structured fishbone analysis keeps going. Why did the nurse misread the order? Well, maybe the process was faulty.
How so?
Maybe the hospital's medication ordering system is badly designed. Maybe it requires the nurse to manually transcribe information between 2 different electronic medical records.
Which introduces a huge potential for error.
A huge potential. So then you ask, why is the system so badly designed? And maybe that leads you to the measurement category. The system wasn't properly tested for usability before they rolled it out. Or maybe it's a policy failure. The hospital decided to prioritize cost savings on IT instead of investing in a single robust system.
So the blame, which looked like it was on the person,
Right.
is actually a failure of policy and process.
Precisely. The whole goal is to shift the thinking from who messed up to what system allowed this to happen. By forcing the team to list causes in all these other categories, materials, methods, machines, before you get to people, the fishbone helps ensure you're finding the real underlying factors, not just the symptoms.
And it creates a shared understanding for the whole team.
A shared, comprehensive insight.
Right.
And the source material is really clear on this. When you use these tools routinely, and you do it fairly and transparently, it leads to much more engaged and satisfied employees.
Because it shows that leadership is committed to fixing the system, not just pointing fingers.
Exactly. Not just punishing individuals.
Okay, that systematic analysis is a perfect bridge to our next big topic. We're scaling up. We're moving from troubleshooting one single small problem to evaluating the total health and viability of an entire complex organization.
And this is where we just have to acknowledge the sheer scale of the challenge. Healthcare systems, especially big hospitals, they are just an unparalleled mix of high-stakes operations, specialized talent, complex regulations, and intense financial pressure.
Which is why that Peter Drucker quote about the hospital being the most complex human organization still feels so true.
It absolutely does. And when you're facing that level of complexity, you can't just dive in randomly. You need a structured approach.
Like a systematic physical assessment of a patient. We're kind of looking at the organization as the patient. It has its own anatomy, its own physiology.
Yes, and the gold standard for this kind of organizational assessment, particularly in healthcare quality, relies on three concepts: structure, process, and outcome. This is a framework that was formalized by Avedis Donabedian back in 1978.
And it's still the foundational lens for judging quality today.
It really is.
So let's break down Donabedian's triad. Let's start with structure, the anatomy of the organization. What does that actually cover?
So, structure refers to the dedicated, stable resources and the settings of care. Think of it as the organizational capacity. This includes the physical building, the equipment, the technology.
Okay, the physical stuff.
The physical stuff, yes, but also crucial elements like human resources, nurse staffing levels, the patient-to-nurse ratio, and whether they use advanced practice nurses or if they have special designations like magnet status, which we'll get into later.
So it's the foundational setting.
Yeah.
The capacity to provide care.
That's a great way to put it.
Okay, so structure is the anatomy. Process has to be the physiology, the function.
Exactly. Process refers to how care is actually delivered, the management systems that govern that delivery. This is where you find organizational culture, decision-making models, patient flow, even the reputation of the organization. It's the dynamic interplay of all the parts working together.
And finally, outcome, the results.
Outcome is the objective data. It's the tangible results that matter to the patient and to the people paying the bills. So we're looking at things like morbidity, mortality, patient satisfaction scores.
Like HCHPS.
HCHPS, yes. And readmission rates, complication rates, and you're always comparing the hospital's performance against national targets and similar organizations.
Now, the sources really stress that to do this kind of assessment, well, you can't just look inward. You need external context.
You absolutely have to. A good assessment requires deep knowledge of the mission and the structure, sure, but also an understanding of how it's currently functioning and the ability to gather information from all these different, sometimes conflicting sources.
Internal interviews, public data, external surveys.
All of it. And critically, you have to be open to seeing the organization the way others see it, the public, regulators, competing hospitals, and then compare that performance against reliable benchmarks.
And that's really the goal of our deep dive here, to drill into all of these assessment points: the history, the governance, the culture, patient safety, reputation, outcomes, all structured around Donabedian's framework.
Right.
So let's start dissecting the organization. We'll begin with the anatomy, the structure. Let's start with the basics, history and overview. When you're assessing an organization, why does it matter so much when it was founded and who founded it?
Because the history tells you its original purpose. And that original purpose often shapes its mission and culture for decades, even centuries.
Interesting.
Hospitals are often founded to meet a very specific community need. Maybe it was to serve a military base or a religious group or a specialized group of patients, like in a cancer center. And that founding mission heavily influences its ownership model.
And that ownership model determines everything about its financial and strategic landscape.
Everything.
So let's look at the three main ownership types: not-for-profit, or NFP, for-profit, FP, and governmental. The strategic difference between NFP and FP is really crucial for understanding their priorities, right?
It is. For-profit organizations are pretty straightforward. They operate to distribute profits to their investors, they raise money through stocks and investment, and they pay income and property taxes. Their main driver is short-term profitability.
Shareholder value.
Shareholder value. The not-for-profit hospital is much more complex, mainly because of its tax status.
Okay, how so?
NFT organizations have to reinvest all their profits back into the organization. They can't distribute them to stakeholders. And their huge advantage is their tax exemption.
No state or federal income tax, no property tax.
Which is a massive public subsidy. This status also lets them issue tax-exempt bonds so they can get capital at lower interest rates, and they benefit from charitable donations, which give donors tax write-offs.
That sounds like a pretty great deal for the NFP hospitals, but that tax-exempt status has also drawn a lot of controversy.
A huge amount of controversy, both political and public. The core question is this: Does the community benefit that these hospitals provide? Things like charity care, covering unpaid Medicaid services, running unprofitable but necessary emergency rooms. Does that justify the massive amount of tax revenue that the public is giving out?
And this wasn't just a debate. It actually led to some.
It did. The Affordable Care Act, the ACA, in 2010 went right at this. It mandated a lot more financial reporting and transparency for NFP hospitals.
And the biggest requirement was the CHNA.
The Community Health Needs Assessment. Yes. This was the most significant part. It requires NFP hospitals to conduct a formal CHNA and develop an implementation plan every 3 years.
And the goal of that was?
It was designed to force these hospitals to prove, proactively and transparently, how they are meeting the specific health needs of their local community. It directly links their tax exemption to a demonstrable community impact.
So if you're assessing an NFT organization, you don't just ask about their mission. You go find their most recent CHNA and their implementation plan.
And you compare that to their IRS Form 990, specifically Schedule H, which details all their financial activities and community benefits. That is how you audit their commitment.
Okay, beyond the funding and the ownership, you have the sheer size and scope of the organization. Bed count, patient volume, urban versus rural, all of that defines the structure. And this leads us straight into governance.
Governance is where the buck stops. Both NFP and for-profit systems are governed by a board of directors or a board of trustees. And they hold the ultimate responsibility for two things: financial stability and the quality of care.
And a really crucial part of the assessment is looking at who is on that board. A healthy organization, especially in healthcare, can't just be run by finance people and corporate executives.
That's right. The sources really emphasize that a strong board has to be diverse. It needs to include healthcare professionals, business leaders, and lay members from the community it serves.
And what's a key indicator you look for?
A critical indicator that an organization is truly prioritizing quality and safety is whether key clinical stakeholders are represented at that highest level of governance.
Like the chief nurse executive.
For example, if that clinical expertise is not at the table, there's a huge risk that quality will always take a backseat to financial outcomes.
Okay, now we get to the organization's GPS, its mission, vision, and values. How should we think about these three things when we're assessing a company?
Think of the mission as the GPS itself. It tells you where you are going and what you do. It has to be distinct enough to actually guide your strategy, but simple enough that every single employee can understand it.
Okay. And the vision?
The vision is the destination. It's the challenging future state the organization wants to achieve. It should stretch people. It should inspire them.
And the values are the how?
The values are the ethical compass. They determine how decisions get made, especially when things get tough. They have to be constant and non-negotiable.
And these choices then determine their overall strategy. This brings us to the strategic cultures that Miles and Snow identified back in 1978. Understanding these categories feels like understanding the organization's personality.
It really is like that. They lay out 4 distinct strategic personalities.
Yeah.
The first are the prospectors.
The aggressive innovators.
Exactly. They're always looking for new products, new services, expanding markets. They're often the ones forcing their competitors to react to whatever they do.
And in healthcare, that might be the hospital that's always the first to adopt some cutting-edge new technology.
Right. Then you have the defenders.
The risk-averse ones.
Very risk-averse. They stick to a narrow, secure product line. They prioritize stability and efficiency. They focus intensely on perfecting what they already do, not on looking for new things to do.
Then you have the analyzers. They sound like the pragmatists.
They are. It's a combination strategy. They take less risk than a prospector. They'll watch what their innovative competitors do, and then they'll adopt the new, proven offerings, but only after the market has stabilized.
A balance between stability and innovation.
It's a balance, yes.
And finally, the reactors. I'm guessing this is the personality you really don't want to find when you're doing an assessment.
A reactor strategy is basically defined by a lack of focus. They only respond to external changes, new regulations, a competitor's move, new technology, when they are absolutely forced to.
So the symptom you would see is outdated equipment, poor infrastructure,
and a constant state of scrambling to put out fires.
Yeah.
Yes.
And this strategy is formally represented by the organizational structure, which you usually see in that classic pyramid-shaped org chart. But we've seen a real shift here from that traditional hierarchy to flatter structures.
The traditional hierarchy has all these layers, with every person reporting up to someone else. It's a very centralized decision-making structure.
Right.
The trend, especially in industries that need to be responsive, is toward flatter, more horizontal structures. You get rid of layers of middle management. The idea is to improve communication speed and make the whole organization more responsive to changing consumer needs or, a health crisis.
But that formal chart, the org chart, that's only half the story. You have to look at the informal structure.
This is the shadow organization.
Yeah.
This is the real power structure. The informal structure is the culture, the norms, the social networks, all the unwritten rules that dictate how work actually gets done.
So a good assessment has to check if the formal structure, who should be in charge, matches the informal one who's actually calling the shots.
Yes. And when there's a big gap between those two, that is a sign of deep systemic weakness.
Okay, we've laid out the anatomy, the structure, the resources. Now let's dig into the hard part. How the organization actually behaves, the physiology of its processes. And we start with authority and decision-making.
So authority is typically delegated from the board down to the CEO and the executive team. The critical variable here is the style of that decision-making. Is it centralized?
Top down, like in a hierarchy.
Right. Or is it decentralized and shared, where you're getting input from all different levels of employees, which you see more in those flatter organizations?
And when you're assessing a healthcare system, you're specifically looking for leadership models like shared governance, which explicitly brings nurses and other frontline staff into those key decisions.
And that shared involvement is so important because it speaks directly to the organizational culture.
The way we do things around here.
Exactly. Edgar Schein defined culture as that pattern of shared, unspoken assumptions. It's the learned way a group perceives, thinks, and feels about solving problems. It's pervasive, it's enduring, and it includes all the written and, more importantly, all the unwritten rules.
And you don't just have one culture in a big organization, you have subcultures.
Oh, absolutely. You have the physician culture, the nursing culture, the administrative culture, even the culture of the ICU is totally different from the culture of the pediatric unit.
So your assessment questions have to get at that. What does this organization really value? Is the culture risk-averse, or does it support innovation? Are people rewarded for hiding mistakes or for reporting them?
That last point brings us right to patient safety culture, which the sources establish as the absolute foundation. Florence Nightingale told us this in 1863. The first requirement in a hospital is that it should do the sick no harm.
And that idea gained a new urgency with the IOM's 2000 report, "To Err is Human."
It did. It quantified the just shocking number of preventable deaths and injuries in hospitals. And even after 2 decades of really focused effort, preventable harm is still a huge issue. The fundamental conclusion from all of this work is that you can't achieve safety just by writing more rules or measuring outcomes.
It requires a deep cultural transformation.
Yes, you have to achieve a culture of trust, reporting, transparency, and discipline. Which brings us to the 3 intertwined components outlined by Reason and Hobbes.
Okay, what are they?
First is the just culture. This is the foundation. There has to be trust between the staff and management. Acceptable and unacceptable behaviors have to be clearly defined, and fairness has to be consistent.
So staff have to trust that if they make an honest mistake while following the process, they won't be unfairly punished.
They have to, which leads to the second component, the reporting culture.
This is where staff feels safe enough to report errors, and especially near misses.
Yes, near misses are critical. When a safety event almost happens, but somebody catches it in time. This requires management to commit to fixing the process that caused the error, not just finding the person involved. If you don't have a just culture, reporting just dries up completely.
And that leads to the third part, the learning culture.
This is the strategic use of all that data. The organization has to actually learn from its errors and its near misses. It has to adapt its processes and policies. If a hospital isn't actively reviewing its safety reports and making changes,
It's a reactor in safety.
it's a reactor in safety, yes. And the HRQ further defines what you need to evaluate here. Things like teamwork, adequate staffing, communication about error, and those critical handoff procedures between shifts.
This continuous focus on anticipating failure and adapting, this is the very definition of a high reliability organization, or HRO.
Right. These are organizations that operate in totally unforgiving environments, like nuclear plants or hospitals, where failure is just not an option. And they aim for what's called persistent mindfulness through 5 specific processes.
Okay, let's go through them. The first one is a preoccupation with failure.
Which sounds negative, but it's not. It means being obsessed not just with the catastrophic failures, but with every tiny imperfection, every near miss. You have to view every single error as a symptom of a larger problem.
Second is a reluctance to simplify interpretations.
They refuse to accept the easy surface-level answer. This goes right back to our fishbone diagram. They're always asking why, over and over again, looking for the systemic flaw, not just the individual mistake.
Third, sensitivity to operations.
This is about profound situational awareness. They are highly attuned to very small signals, subtle changes in the environment, so they can anticipate problems before they happen instead of just reacting to them.
Okay, the fourth one sounds really tough to implement. Deference to expertise.
This might be the most challenging one for a rigid, traditional hospital hierarchy. It means you actively listen to the person who knows the situation best, the frontline nurse, the surgical tech, regardless of their official title.
So if the lowest ranking person in the room has the critical piece of information, their voice has to carry the most weight.
It has to. And it's why organizations that do this well have often had to fundamentally flatten their decision-making processes and actively train people against their ingrained hierarchical habits.
It's rare.
A culture where a resident can comfortably challenge a senior surgeon on a safety risk is very rare, but it's the absolute hallmark of high reliability.
And the final process is a commitment to resilience.
The ability to keep functioning despite adversity, to bounce back quickly, learn from what happened, and actually grow stronger. So when you're assessing an organization's process, you're looking for real evidence of these 5 principles in action.
And this whole process framework depends heavily on the quality of the work environment.
Oh, absolutely. The quality of the work environment is directly statistically linked to patient outcomes. Poor environments, with inadequate staffing, disrespect, poor communication, they are linked to really negative patient outcomes.
More patient falls, more readmissions.
Lower quality of care, yes. And on the flip side, a healthy work environment includes physical and mental safety, collaboration, effective leadership, and crucially, adequate staffing, both in the number of people and in their competency.
Okay, so we've covered the structure and the operational processes. Now we get to the outcomes. The external validation, the transparency metrics that publicly judge an organization's performance.
And when we define quality, we have to go back to the IOM, which gave us the gold standard definition in 2001. Quality care has to meet the 6 aims.
Right. It must be safe, effective, patient-centered, timely, efficient, and equitable.
Those 6 aims.
Now, listing them is easy, but achieving all 6 seems to be the great challenge. Of those 6, which one do you think is still the most systemic failure in U.S. healthcare?
I think most experts would point to equitable care. While we've made real strides in safety and effectiveness, equitable care, meaning care that doesn't vary in quality based on a patient's race or ethnicity or socioeconomic status, that remains a massive, persistent, systemic failure.
And why is that so hard to fix?
It's extraordinarily hard because it requires overcoming these deep structural and cultural biases that are often hidden inside the process of care delivery itself.
And to even start to address that, you need transparency. Our sources argue it's essential for 3 reasons.
First, transparency helps providers improve by letting them benchmark their performance against their peers and national averages.
Okay.
Second, it encourages insurers and public programs to reward quality and efficiency, linking payment to value. And third, it empowers patients to make more informed choices about where they get their care.
And this transparency shows up in things like the big U.S. News and World Report rankings, which look at quality data and external recognition like magnet status. But the most important national metric for the human side of care is HCHPS.
HCHPS, yes, the Hospital Consumer Assessment of Healthcare Providers and Systems.
Yes.
This survey is so strategically important because it was the first national, standardized, publicly reported survey to capture the patient's perspective.
So before this, hospitals could just rely on their clinical metrics, which might ignore the patient experience.
They could, and they did. HCHPS forces hospitals to focus on process elements that are often undervalued in a purely clinical model: communication, responsiveness, comfort.
What does it ask?
It asks 32 questions, with 22 core questions about things like communication with nurses and doctors, responsiveness to the call button, pain management, the clarity of discharge information, and then it asks for an overall rating and whether you'd recommend the hospital.
And the results are public and, importantly, they're adjusted.
Yes, they're adjusted for factors outside the hospital's control, like the patient's age or health status. This is to make sure hospitals are being compared fairly on their performance, not just on how sick their patients are.
Beyond the patient experience, organizations are held accountable for specific clinical outcomes by big regulatory systems. Let's talk about the power structure here between the Joint Commission, TJC, and CMS.
This relationship is a classic example of how a private entity can wield massive governmental power. TJC is a private, nonprofit organization that provides voluntary accreditation. But achieving TJC accreditation is a requirement for a hospital to receive Medicare and Medicaid reimbursement.
So TJC basically holds the keys to the kingdom. If they pull your accreditation, the federal money stops.
Exactly. And that leverage forces organizational behavior. TJC sets mandatory requirements, like the National Patient Safety Goals, which demand huge changes in hospital safety practices. And by aligning their standards with CMS, they created these standardized core measure sets that focus on improving care for high-risk conditions like heart failure and stroke.
And this accountability also extends to preventing things that happen during the stay, like hospital-acquired conditions and infections.
Right, HACs and HAIs.
Hmm.
Monitoring things like bloodstream infections or UTIs is crucial because if you're an outlier in these areas, it's a clear signal that your processes are failing compared to best practices.
And this is backed up by a pretty big financial stick, the Hospital Value-Based Purchasing Program.
VBP is CMS's most powerful tool for linking Medicare payment directly to value, not just volume. Hospitals get financially rewarded for good performance and penalized for poor performance on quality measures.
And the clearest example is readmissions.
Readmissions, yes. If too many of your patients bounce back to the hospital within 30 days, CMS reduces its payments. This is the government translating poor quality outcomes into direct financial pain for the hospital.
And finally, let's look at the external accreditations that signal excellence, especially in nursing, which seems to correlate with better outcomes across the board.
Magnet designation from the ANCC is the absolute pinnacle. It's an incredibly rigorous process. Only about 7% of U.S. hospitals have it, and you have to renew it every 4 years.
And it focuses on leadership.
It focuses heavily on transformational leadership and requires tracking specific nurse-sensitive indicators like patient falls and pressure ulcers. The fact that basically all the hospitals in the U.S. News Best Hospitals list are magnet designated tells you everything you need to know about its status.
And there's also the Beacon Award for Excellence, which is at the unit level.
Right. The Beacon Award recognizes a positive, high-performing work environment at the specific unit level, like an ICU or an emergency department. It's a sign that the underlying structure and process are fundamentally sound in that specific area.
Okay, so we've established that there's just widespread variation in healthcare. And all of these frameworks we've reviewed, from Donabedian to the core measures, they're all designed to fight that inconsistency by driving standardization through evidence-based practice, or EBP.
Standardization is the goal. It ensures that the patient gets the optimal, scientifically validated treatment no matter which doctor, which shift, or which hospital they go to. But we need to be clear about the different tools used to get there. There's a kind of hierarchy: standards, guidelines, protocols, and best practices.
Okay, let's start at the top with standards.
A standard is the minimum expected level of care. It reflects a desired and achievable level of performance. In the legal world, this is the standard of care, the benchmark a clinician's actions are judged against in court.
And below that, we have guidelines.
Guidelines, specifically clinical practice guidelines, are systematically developed statements, usually based on scientific evidence, designed to help doctors and patients make decisions about care for specific clinical situations. They clarify what should be done.
Then we get even more specific with protocols. How is a protocol functionally different from a guideline?
A protocol is highly detailed. It's often specific to one hospital, and it defines a set of rigid rules for a specific circumstance. Think of a checklist for preventing a central line infection.
So it's designed to reduce variation to zero.
Exactly. Unlike guidelines, which offer decision support, protocols are generally expected to be followed to the letter, unless there's a very specific, documented clinical reason not to.
And finally, best practices, which are the most informal.
Right. A best practice is a process or a technique that seems to result in better outcomes, but it's often informally accepted. It usually lacks the formal, rigorous scientific backing of a published guideline.
And all of these tools feed into what we consider the gold standard of care. Evidence-based practice, or EBP. What does that term truly mean?
EBP is a problem-solving approach.
Yeah.
It's about systematically integrating the best available, most rigorous research evidence with the best available experiential evidence.
Which means the doctor's clinical expertise and the patient's own preferences and values.
Exactly. It should be the foundation of every clinical decision.
And yet, the sources reveal this staggering gap. Only about 20% of clinical decisions are estimated to actually be evidence-based. Why is there such a huge lag?
It's a really multifaceted problem.
Yeah.
While randomized controlled trials, or RCTs, are the gold standard for research, we also rely on other kinds of research descriptive, qualitative. The qualitative work is so important because it gives us insight into the patient experience.
But the gap exists
The
because
gap exists because translating all that complex research into actionable, universally adopted guidelines is just incredibly difficult.
So, when a doctor or a nurse is trying to evaluate a guideline, they need tools to grade the evidence, to decide which one is the best fit.
Right. First, you have to structure the clinical question, often using the PI-CHOD framework.
Patient, intervention, comparison, outcome, and time.
Right. Once you have your question, you can apply grading systems to assess the quality of the evidence that supports a recommendation.
Like the U.S. Preventive Services Task Force grading system?
Yes. The USPSTS system stratifies both the quality of the evidence, high, moderate, or low, and the strength of the recommendation, grade A, B, C, D, or I.
So a grade A means you absolutely should offer the service.
High certainty the benefit is substantial, yes. And a grade D means you should recommend against it because the harms outweigh the benefits. These grading systems are designed to provide absolute clarity.
And there's also the hierarchy system that classifies the type of research.
That hierarchy, often from Melnick and Fineout-Overholt, puts level I evidence at the very top. That's a systematic review or meta-analysis of all the relevant RCTs, and it scales all the way down to level 7, which is just the opinion of an expert committee. A strong guideline is built on the highest level of evidence available.
We've mentioned the immense influence of external organizations in shaping these practices. CMS, TJC, AHRQ, they're all pushing for standardization.
They form an ecosystem. AHRQ funds the research that builds the evidence base. TJC enforces the application of that evidence through its accreditation process, and CMS enforces it through financial reimbursement policies like VBP. They are the system that drives evidence from the lab to the bedside.
But knowing the evidence is just the first step. The biggest systemic challenge seems to be the implementation gap, just getting these published guidelines adopted into routine practice.
Implementation is a massive structural and cultural hurdle. The sources say it can take up to 5 years for robust published guidelines to be widely adopted across an organization.
And the barriers are?
Yeah, they're numerous. A simple lack of awareness that the guideline even exists. A lack of agreement among the clinicians about whether it applies. A lack of confidence to perform the new procedure. And just the sheer inertia of, we've always done it this way.
The "we've always done it this way" trap. So if an assessment shows this gap between evidence and practice, what does it take to actually implement the change successfully?
It takes deep organizational commitment. You need buy-in from senior staff and you need resources. Leaders and clinicians have to be invested. This often means redesigning care processes, doing targeted training, and providing decision support tools.
Like pop-ups in the electronic medical record that guide the doctor toward the right protocol?
Exactly.
And crucially, even with this big push for standardization, the process has to remain patient-centered.
It absolutely must.
Yeah.
The final critical step in the EBP model is tailoring that standardized evidence to the specific organization, the specific practice environment, and most importantly, to the individual patient's preferences, values, and clinical circumstances. Standardization is there to reduce dangerous variation, but it must never override the unique needs of the person receiving the care.
This has been an incredibly rigorous deep dive into structured thinking. We started really small, learning the mechanics of the fishbone diagram, how to dissect a messy problem into the 6 M's or P's, and I think most importantly, how to avoid that people trap by looking for systemic process issues first.
And then we scaled all the way up to evaluate the total macro system using the Donabedian framework of structure, process, and outcome. These models provide the essential blueprints for understanding how these complex organizations are governed, how they're measured by external quality indicators like HCHPS and magnet status,
and how they're driven towards standardization through the application of evidence-based practice. For you, the learner, I think the ultimate value here is gaining the ability to diagnose systemic failure quickly. You can now look past the surface symptoms of, say, a failed project or a struggling organization and ask, is this a failure of structure? Do we have inadequate resources, poor governance, a bad strategy?
or is it a failure of process, a toxic culture, a breakdown in safety or decision-making? Or finally, is it a failure of evidence? Is there a gap in standardization, or just a persistent inability to implement the protocols we know work?
We've seen just how hard it is to implement positive, evidence-based change, even when lives are on the line.
It's incredibly difficult. And that brings up a final thought. If evidence-based guidelines for physical health, with all that scientific backing, struggle so much for adoption, You have to wonder about the unseen structures and informal norms in your own field. Think about the unwritten rules of your workplace, those informal structures that always seem to override the published rational policies. What systemic flaw in your organizational culture is actively resisting the most obvious improvement, that cultural resistance? That is often the root cause the Fishbone diagram is truly searching for.